Great. Okay, thank you. Well, I am Dr. Rachel Sosland, and I am so excited to do this webinar on overactive bladder and bladder issues. I started with Urology Austin back in October of 2020. I completed my urologic residency training at Vanderbilt University in Nashville, Tennessee. And then I went on to do a fellowship specifically in voiding dysfunction. So what voiding dysfunction means is, excuse me one second, let me make sure we get this going. Give me 1 second. There we go. Okay, much better. So voiding dysfunction is an issue with bladder. So that could be bladder emptying, it can be the inability to empty the bladder, or it can be incontinence. And so this occurs in both men and women. And I spent my year in fellowship really studying how the bladder works and how to best treat patients with these issues. So it's a problem that is near and dear to my heart. And I'm so excited that we have the opportunity now with so many different medications and treatments and technologies to really improve your quality of life. So we can find treatment options that match your goals of care. And again, just make your quality of life better. And so again, we'll talk in detail about these issues today, but also about the treatment options. I am currently practicing in South Austin at the Radom location and also at Medical Park Tower. The number you can see on the screen is a great way to reach me. And I'll provide this at the end of the presentation as well, so that if you have any questions, you can reach out, schedule an appointment, and we can talk in detail about you specifically. Okay, so you may have joined this webinar because you or somebody you know is having issues with bladder control. And you may have attributed this to it being a side effect of a surgery you had, potentially childbearing or a natural aging process, but it is a real problem. And many people probably don't talk about it. So you may resonate with some of the quotes you see here on the screen about if you'll ever regain control. You may have limited personal outgoings, personal relationships. You may have found that you bring extra sets of clothes or pads that you have started wearing. And many people don't talk about this. 44% of people say that they're too embarrassed to talk about their bladder problems. And the issue is that as physicians, we're not great at bringing it up. So if we don't bring it up and you don't talk about it and you're too embarrassed, then the problem never gets addressed, which is a shame because we have several treatment options for it. So one of my goals today is to show you that you can have a life without limits. We can give you back, you can regain control of your life, and we can help you do that through several different mechanisms. So in our agenda today, we're first going to talk about understanding bladder control and what that means. We're also going to talk about the care pathway. So most recently in 2019, 2 organizations, including the American Urologic Association, came up with a pathway for how we deal with bladder issues. And so we have a very systemic way of moving from conservative to more aggressive treatment options to get you better. We'll talk about those treatment options, specifically 2 treatment options from Medtronic, including InterStim and the NURO system. And then there'll be plenty of time for questions and answers at the end. And as Joanne mentioned, you can type these in to the box, the question and answer box, and I'll be able to address each of those. And if you have any specific personal questions, you can set up an appointment with me and we can talk about you specifically in detail. Okay, so the first thing I want you to know is that you are not alone, that overactive bladder is incredibly common, that 1 in 6 adults has overactive bladder, and this happens in both men and in women. That's 37 million Americans adults, both men and women, have overactive bladder. And that's more than people with vision problems, more than people with diabetes. So you may be asking, if it's so common, why you haven't heard about it. Many people self-monitor. So you have and self-manage. So you may notice that you just choose to not go out as often. You may notice that when you go to a mall or you go shopping or grocery shopping that you map out all the bathrooms, but it's probably pretty unlikely that you're talking to many people about this. And like I said before, if no one asks you about it, it's unlikely that you're going to share. Like I said before, it affects men and women of all ages. It is not just a natural process of aging. And ignoring this overactive bladder can lead to several chronic issues, including loss of sleep. The older you get, the more detrimental that becomes. It can lead to falls. It can lead to memory loss, loss of confidence, also loss of self-esteem, as you probably have experienced yourself, and just overall fatigue and poor feelings of general health. So let's talk about what's normal and what isn't normal. So urinary incontinence is not a normal part of aging, as I've mentioned a couple times already. There are two different types of urinary incontinence. We talk about stress incontinence and urge incontinence, and we'll get into those details. Within urinary incontinence and urge incontinence, we have overactive bladder wet and overactive bladder dry. And I'm distinguishing these because you may be listening to us and saying, well, I don't leak. And even if you don't leak, going frequently, more than every 2 to 3 hours per day, or having the urgency to get to the bathroom, even if you don't leak before you make it to the bathroom, is still not normal. And this is still within the spectrum of abnormal bladder function and overactive bladder. So we can help you too. Some of these bullet points that you see here, going more than 8 times a day, I say if you're going more than every 1 to 2 hours, that's abnormal. Having urgency, needing to rush to the bathroom, sometimes leaking before you get to the bathroom, having to plan your activities around going to the bathroom. I have many patients that say that as soon as they get home and they put their hand on the door handle that they start to leak. I have patients that say they can't wash dishes anymore because as soon as they hear running water, they feel like they immediately have to go or they start to leak. This is all a sign that your body's trying to tell you something and that your bladder is being overactive and isn't really functioning the way that it should. So let's talk more about bladder control and how it should work. So your bladder is a muscle and it has nerves that come from the brain and the spinal cord that connect. Now these same nerves, specifically the third sacral nerve, also supplies the bowel. So the bowel and the bladder go hand in hand. And what should happen is that your bladder as a muscle is collapsed when it's empty. And as you start to make urine, that should fill up. And when it gets to be a certain fullness, then it sends signals to your brain that says, we got to go, let's go to the bathroom. You should be able to hold it. So as your bladder is filling, your bladder should fill and be very quiet. It shouldn't move. You shouldn't have urgency. You shouldn't be leaking. It should fill and be very quiet. And then when you give permission from your brain, it sends signals to your bladder to allow the pelvic floor to relax and your bladder to squeeze and empty completely. So it really relies on the communication from your brain, your spinal cord, and the nerves that supply the bladder and the bladder muscle to be coordinated in order for you to have adequate emptying. So the brain and bladder communication is essential for bladder control, also for bowel control. And any communication breakdown in this entire pathway can lead to bladder control problems. So it's part of my job to figure out where in the pathway the issue is and to figure out what treatment option is best to treat where your issue is. So what causes bladder control problems? This can be as simple as dietary irritants or behavioral issues. So for example, some people hold their urine for too long. I recommend that you try to go to the bathroom every 2 to 3 hours, even if you feel like you don't need to. Many of you are probably thinking that there's no way you could hold it 2 to 3 hours, and that's a different issue. Going to the bathroom every 2 to 3 hours and trying to minimize your fluid intake 2 hours before bedtime are kind of general rules of thumb for good bladder habits. Now, several things can irritate the bladder. If you come to my office, I'll give you a handout on bladder and dietary irritants. Things like spicy foods, alcohol, caffeine, acidic foods, things that we love to eat and drink can all irritate the bladder. In addition, medications and supplements you may be taking. Some of you may be taking diuretics that can increase the amount of urine that you produce. Your bladder fills more frequently and you may have to go to the bathroom more frequently. Similarly, there are medications that actually can slow your bladder down. And then finally, pregnancy, childbirth, and any pelvic floor injury can also cause bladder control problems. I like to think of the pelvic floor as a bucket. It's a bucket of muscles and strength tissue. And anytime we have surgery, you have children, those muscles and that support can get weaker. And when that gets weaker, it can cause issues with your bladder. Now, specifically in men who have had a prostate problem for a long time, if the prostate's big and it's causing a blockage, then your bladder is having to squeeze hard for a long period of time to try to get urine past that prostate. And even sometimes after a surgery where your prostate's been unblocked, your bladder's been working so hard for so long that some of that, it can cause irreversible damage. And some of those bladder muscle fibers are still going to be hyperactive. So we may treat your prostate problem, but we may have created a bladder problem over time with that prostate being so big. So those are kind of general examples of where I see people have bladder control issues. So the three most common bladder problems are stress incontinence, urinary retention, and overactive bladder. And we're going to talk about each one of these in detail. So it is very important to differentiate between stress incontinence and urge incontinence. I have so many patients that come in and they know that they leak, but they know that they have urgency, but they don't know why they're doing it. So the reason it's so important to know the difference is because they happen for different reasons and because they're treated in very different ways. So part of my job is to help you figure out which of these is more bothersome. Many people have mixed incontinence, which is both stress and urge incontinence, and we can fix both problems, but we have to know what we're dealing with. And I normally try to fix the most bothersome symptom first. So what is stress incontinence? Stress incontinence results from a weakened pelvic floor, as I was talking about earlier. So that lack of support, which can happen after surgeries or happen after childbirth. And this is leaking when you cough, sneeze, or laugh. So this is any increase in abdominal pressure. When you exercise, when you stand up or move positions and you leak, that's likely due to stress incontinence, which is, again, weakness in that pelvic floor. So we can do exercises to try to strengthen the pelvic floor, and that's a great place to start. But oftentimes those conservative measures fail, and we have to proceed to something different, which most of the time is surgery and surgical repair to correct this. Okay, second, we have urinary retention. So this is the opposite of incontinence, and this is incomplete bladder emptying. So again, the bladder is a muscle, and either the muscle can weaken over time or the nerves that supply the bladder can have issues. And when that happens, you can have urinary retention. So your bladder is not squeezing in a coordinated way, as I spoke about earlier, to empty your bladder. You can have a weak and dribbling stream, and we have several ways to manage this. Some people have to use a catheter and pass a catheter into the bladder to help get the urine out. It's important to distinguish between two different types of urinary retention. So again, part of my job is to figure out, are you not able to empty your bladder because something's blocking it, like prolapse, for example, or a big prostate, or is it that nothing's blocking it, but in fact, the bladder isn't squeezing like it should? We'll get to the importance of that later, and some of the applications of our treatment options depend on which of those two types of retention you have. Okay, finally, overactive bladder. So overactive bladder is really defined by two different symptomatologies, I should say. One is urge incontinence. So again, this is this OAB wet. This is leaking before you get to the bathroom. Sometimes people leak even at the end of going to the bathroom. They'll leak as they stand up. This is waking up at night to pee, sometimes being wet at night and waking up wet. Frequent leaks and needing to use things like pads or changing your clothes. There's also OAB dry. So this is urgency and frequency. This is this uncontrollable need to go or going again more often than every 1 to 2 hours. Okay, so I told you about all these options. The good news is that we have treatment options for them. And most recently, as I mentioned before, in 2019, we received updated guidelines from guidelines that were started in 2012 that tell us how to manage these. So with this problem, we have a really systematic way of progressing you through conservative to more aggressive treatment options to improve your quality of life. So we're going to look at each one of these in detail. So lifestyle changes. Now, I've already kind of told you about this, but lifestyle changes come with avoiding dietary irritants, things like spicy foods, caffeine, alcohol, avoiding fluid 2 hours before bedtime to prevent you from waking up at night to pee. Exercise and weight loss can help not only strengthen your pelvic floor, but also weight loss has been associated with a decrease in incontinence. Even small amounts in your body mass index can make a big difference with regards to your urinary incontinence. We also have pelvic floor exercises. So you may have heard of things like Kegels, which is pelvic floor strengthening. So those are really good for some conditions, and for other conditions, they actually make the problem worse. And what we want to work on is actually urge suppression and relaxation of the pelvic floor, relaxation of the bladder. So if you're unable to figure this out on your own, we have excellent pelvic floor physical therapists. We have some that work with Urology Austin as well, and they can help you really figure out what's going on with your body and your pelvic floor, and then figure out how to modulate that. If those conservative measures don't work, we also have oral medications. So we have two different types of oral medications. The first is called, or the class of anticholinergics. Anticholinergic medications have been around for a really long time. I call them the dirty drugs because they are great, they're generic, oftentimes they're cheap, but they have side effects. And the side effects that we typically see are dry eyes, dry mouth, and constipation. And not everyone gets these side effects, but you can get them and they can be pretty severe. In addition to those side effects, there have been new studies that show that in older patients, specifically patients older than 65, that there can be an association with confusion and with memory loss. And there was a recent large study funded by the National Institute of Aging that was published in JAMA, the Journal of American Medical Association, that has shown that elderly people who take anticholinergic medications are at greater risk for developing dementia. So in my practice, I avoid it at all costs in patients over 70 years old. Now there's a second type of medication. These are beta-3 agonists. And so there are now two types of these medications on the market, mirabetril or mirabegron and Gemtesa. Now, mirabetril can have a side effect of increasing blood pressure, so we have to watch out for that. It also can have some side effects with certain medications, so you may not be a candidate for that. And Gemtesa is brand new on the market, just a couple months old. And the biggest side effect with both of those is the cost to your pocketbook. So they can be expensive. And because of the cost, because of the side effects, many people stop medications. In fact, 72% of patients say that they stop taking a bladder medication after 6 months. So at this point, when you're a patient of mine and we have failed conservative measures and we have failed medications, then we talk about moving on to third-line therapies, which are the advanced therapies. And in order to figure out if you're a good candidate for these and which you're a good candidate for, I may ask that we proceed with some testing first. So some of the diagnostic tests that I use are things like cystoscopy, which is looking inside the bladder with a very small camera. And the other is a urodynamic test, which looks at the physics of the bladder, how the bladder is working, how it fills and empties. That's not required in every patient, but sometimes it's useful to figure out really how to proceed if you have a complex case. So for advanced therapies, we have three options. One is the Medtronic InterStim system, which you probably have all heard about and why you're here. We also have the NURO system, which we'll talk more about, and then Botox injections into the bladder. So we'll start with talking about Botox injections. Botox is a muscle paralytic, and you may have heard that people use it in their face or in other places to relax muscles, and that's exactly what it does, is it relaxes muscles. And we talked about how your bladder is a muscle. So the way that I perform Botox injection, I do this in the office, and with a cystoscope or a small camera, I look inside the bladder and we fill your bladder up first with lidocaine, a numbing medicine, but then with fluid. And I put 10 small injections of Botox in the bladder. Now, Botox, as you may already know, doesn't last forever. We have to re-inject it about every 6 to 9 months because it wears off. And there are two big side effects with Botox injections. The first is urinary tract infection, which happens in about 30% of people. So I always give people a couple of days of antibiotics at the time of their injection. And then the second is urinary retention. So in 6.5% of people, we over-relax the bladder so much that you can't empty your bladder completely. And you may have to catheterize or wear a catheter for a certain amount of time. Typically, that's about 2 weeks until the Botox wears off a little bit. Sometimes it's longer, but again, eventually the Botox will wear off. So it's convenient. We can do it in the office, but it does have some side effects. And about 51% of people stop after 2 treatments because you do have to keep it up. Okay, next we're going to talk about PTNM, and this is peripheral tibial neuromodulation. Now, what this looks like, you can see in the picture, it's almost like a little acupuncture needle. And so this goes into the tibial nerve, which is a nerve that sits right on the outside of your ankle. This is a good option for people who have failed other treatment options or aren't a candidate for some of them, maybe not a good surgical candidate or someone who's failed medication or can't take the medication. But it does require a lot of in-office time. So what happens, these are 30-minute sessions where we use this little needle and we stimulate the nerve, and that communicates and works on modulating the bladder. Now, it does it over a period of time, and you don't normally get to see the results immediately. So it may take several sessions before you really notice a difference. Each session is 30 minutes long. These are in the office, and you have to do it consecutively for 12 weeks, which means you come once a week for 12 weeks to the office for a 30-minute session. Now, after that, you have to maintain this by every 3 to 4 weeks coming back in for another session. And if you don't come in for those maintenance sessions, then the effects of this will wear off. So it really does require that you come in and that you have good compliance with the treatment options. Okay, finally, InterStim. So this is sacral neuromodulation. And just like we talked about when I told you how the bladder and the brain work together, what we're doing is we are modulating the bladder and bladder function through the third sacral nerve, which is one of the nerves that comes off the spinal cord. And that's a nerve that supplies both the brain and the bladder. So it gently stimulates the nerve and the communication pathway to help fix whatever is going on with your bladder. Is the best way to explain it. So it's providing gentle stimulation to regulate it so that it fills and empties in a more normal state. Now, the way that I perform sacral neuromodulation is with a 2-stage process. Now, depending on exactly what your issue is and our conversations and what's going on, we will choose to go one path or the other. But in general, the way that I like to set this up is to do a 2-part test. So we test it out before we implant the device. Think of this like a pacemaker. So I actually have 2, you can see in the picture, and I want to show you for size what exactly we're talking about when we talk about implantation. So there is a rechargeable and a non-rechargeable InterStim. So first I'm going to show you the non-rechargeable and just the size, if I can get this in the screen here. So here's my hand, and then here is a non-rechargeable generator or the battery that supplies the stimulation. And then here is the rechargeable. So you can see both are much smaller than the palm of my hand and both small in size. So before we make the decision about whether or not you want to implant the device and whether or not you want the rechargeable or non-rechargeable, we test it out. So what we'll do is you'll come to the office, we'll talk about this, and then I perform my first test, which is called a peripheral nerve evaluation in the surgery center nearby. So you'll come to the surgery center in under about a 20-minute procedure with just local anesthesia and kind of some laughing gas. You don't go completely to sleep. I'll place 2 small wires through the holes in your sacrum, and I'll lay them next to the nerves that supply the bladder. And then you'll walk around for about 5 days with a little fanny pack on, and that will be stimulating your bladder. Now, you'll have excellent help, and we have excellent support through Medtronic. So someone will be calling you every day to make sure that you're doing well, that your settings that they're working. And if not, we'll adjust your settings to try to get you the best response. You should notice a significant improvement in your urgency, your frequency, your leakage. And if you do have non-obstructive urinary retention, you should be able to empty your bladder better. So when you come back to the office, we'll review whether you're not better. And if you're at least 50% improved, then we'll be able to implant the device. That's when we make the decision about whether or not we'll use the non-rechargeable or the rechargeable. Now, the difference between the two. The non-rechargeable device comes with a permanent lead. So if you choose to implant it, we'll implant a permanent lead, and then we'll connect this. I'll implant this in the fat that sits over your butt. And this lasts for about 5 to 7 years. You do not need to recharge it. So once it goes in, you don't need to think about it once you're on the right settings. But at about 5 to 7 years, it runs out of juice, and then we'll have to replace it, which means I'll have to make a little incision over where it was implanted, pull it out, and hook up a new one. It takes me about 15 minutes. Alternatively, we have the rechargeable. So the rechargeable is even smaller. This will last about 15 years, although you do have to recharge it once a week. And that lasts about 20 minutes. You recharge it through the skin by tucking a little recharger in the back of your pants or attaching it with a belt that we give you. And that will recharge it enough to last you really on general about a week to 2 weeks. So again, this is a slide on saying yes to the test. I can't emphasize enough that we test it out before we implant it. Now, in a small portion of patients, I will, instead of placing 2 temporary wires, we'll go ahead and place the permanent wire in our first session, and then implant the generator in the second session if it works, versus just pull the wire out. And we'll make the determination about which path we need to do depending on you and your history and your anatomy. So this is a safe and effective treatment option. I love this treatment option. I implant a lot of these because it really changes the quality of life for my patients. I have patients that have been miserable for years with urgency, frequency, and leakage, and they come back and they tell me that it's completely changed their life, that they've developed personal relationships that they had abandoned, and that makes me really happy as a physician. Overall, 84% satisfaction among people who use it. Compared to medications, there's a 3 times greater improvement in quality of life. And 76% of people achieve success compared to 49% of patients on medication. So, is this therapy right for you? You may be a good candidate for the bladder control therapy with Medtronic if you have overactive bladder symptoms like the urgency, frequency, waking up at night to pee and leakage, or non-obstructive urinary retention, meaning that we've shown that you don't have a blockage, but that you're still not totally able to empty your bladder all the way. If you've tried lifestyle changes, you've made those modifications, and you've tried at least 1 medication and have failed it, then your insurance, Medicare will cover it, and many of the commercial payers will also cover this as long as we can prove in our documentation that we've tried these things and that they haven't worked for you. I do want to make one note that in patients with fecal incontinence, this is also an excellent therapy. So for some of you who have urgency, overactive bladder, and also have some bowel issues, InterStim is FDA approved for both indications. So what do we do next? If you would like to talk to me more about this, I would be happy to see you. As I said before, this is near and dear to my heart, and I love taking care of patients with this problem because I feel like we can really make a difference where you thought that there was no hope. So I see patients again at our Radham Lane office and our Medical Park Tower office. You can see my phone number there. I'll say it out loud, which is 512-443-5988. We also at Urology Austin have a concierge OAB navigation program. And what that means is that it's a free it is free to you. The program has no cost. And we have patient navigators that will call you, check in, make sure that you're doing well on your medication. And so they will be calling you in follow-up since you attended this webinar to see if you have any questions. Of course, you can decline that, but if you'd like to make an appointment with any of the specialist who perform any of these procedures in Urology Austin, they'll be able to help facilitate you doing that, whether it's with me or with one of my partners. Again, if you want any more information on Medtronic bowel or bladder control, you can see the 2 websites at the bottom, medtronic.com/bladder relief and medtronic.com/bowel relief. Thank you so much for joining this webinar, and I look forward to meeting many of you. Okay, great. So Joanne is telling me that we have some questions here. So we're going to let me see if I can pull these up. Okay, so I have a question here about a patient who has urgency and frequency, asking if the symptoms mentioned before are related to an active bladder. So yes, so we say that they are related to an overactive bladder. So you should be able to urinate and urinate completely, but urgency and frequency are abnormal. So that's the hyperactive or overactive bladder part, and that's exactly what this is all designed to treat. So we have solutions for you. Okay, I see another patient here that says, I'm taking a medication called tamsulosin for urgent continence and wondering about what the effect of the bladder is with this medication. So tamsulosin, and many of you may have been on tamsulosin before. The other name for that is Flomax. Tamsulosin works on the tissue, specifically on the prostate and the base of the bladder. Now, it's been used in women before as well because some of those same cells are sitting at the base of the bladder, and men and women both have bladders. But what it does is it relaxes the outlet, so it should make you empty better. Now, sometimes in people who have, in men specifically, who may have a prostate problem and have a bladder problem, doctors will start patients on Flomax first or on tamsulosin first. And the reason to do that is to rule out that you can't that it's a prostate problem. Now, like I said before, you may have both problems. If the tamsulosin doesn't work, it may be more a good idea to look into the urge incontinence component. But again, that's something that we could tease out more in the office with some additional tests. One of the things I like to use is a bladder scan. So it's just a small ultrasound probe. We put it over the bladder, and that way we can make sure that you're emptying your bladder completely. And once we go from there, we can try to determine how to best proceed, either the bladder pathway or the outlet, like a prostate pathway. Okay. Another question about, should I be able to sleep 6 or 7 hours a night without waking up to go to the bathroom? Would that be normal? Absolutely. You should be able to sleep 6 to 7 hours a night. And sleep, we know increasingly, we have more and more data about how important sleep is to all of our bodily functions, and especially with brain function and cognitive function. So yes, you should be able to sleep. That is a very reasonable and attainable goal. And we can try to get you there. Even if this is not the only solution to that problem, we have other ways to help get you there as well. Okay. Okay, there's another question about feeling like you have to urinate all the time and then trying to hold that off, but then letting the pelvic floor go and not being able to urinate. So that can be for one of two reasons. Oftentimes I have patients come in with the primary complaint of incomplete bladder emptying and feeling like they just can't, that they have to pee all the time, but they can't get the urine out. If you're going so often that your bladder never gets full, then when you sit down to pee, you really can't get any urine out because there's not that much urine there. So I see that happen pretty often in patients with overactive bladder. It could also be that you have some other pelvic floor dysfunction so that your pelvic floor is too tight, or you have a blockage. And so that when you try to release it, that there's actually an anatomic blockage or obstruction there. So that's something that I wouldn't expect you to know on your own, but something that we would do some investigations and figure out really the reason why you have those symptoms. And there are some, again, really easy tests that we can do in the office in order to be able to distinguish between the two things. Okay, so another question about, is this procedure covered through insurance if you absolutely don't want to take medications? So I need to be able to prove to the insurance companies that we have tried conservative measures, and we can absolutely try to go for an approval. And if they tell me that they come back and say, yes, you have to have tried a medication, then we can work together to work around it to get you the care that you need. And again, happy to talk more about that in detail in person. Okay. Does InterStim help overcome or eliminate the running water problem initiating urges? Yes, that's a short answer. Now, again, InterStim is not going to work in every patient. There's no treatment option that works 100% of the time, but 84% satisfaction rate that yes, we can get you to a point where when we turn water on that you do not have to run to the bathroom. Okay.
Okay, let me know if there's anything else I can help you with.
Okay, let's see. There's another question about stress and OAB, and absolutely stress and anxiety can worsen overactive bladder symptoms. We didn't talk about that in detail, but there is a lot of data to show that as well. So these options, all the options we discussed would be definitely applicable to you. Okay. Okay, this is a good question. There's another question about patients who have symptoms just at night, but don't feel like they have the symptoms during the day. So there are several conditions that can cause you to make more urine at night. And I may ask you, in fact, I probably will ask each of you who comes in to perform a voiding diary, which means that for at least a couple of days, you keep track of when you're going to the bathroom. And that can help me figure out if this is in fact an overactive bladder problem, or if it's a problem with you making too much urine. I have several patients that really just have overactive bladder at night, and that when we treat their overactive bladder, that the symptoms get better, even if they don't notice it during the daytime. But there's a small handful of people that really do just have a different problem, and we can treat that too. Okay, this is a great question too. So drugs like Myrbetriq, do they just treat the symptoms or do they also solve the underlying issue? So in general, we are not curing the problem. So we are not treating it or reversing kind of damage that's already been done through a variety of things. A lot of these, you can think of the drugs as kind of Band-Aids. So if you stop taking the medication, your symptoms will come back most definitely. And that's why some of the third line therapies that require that you don't do something every day and you can kind of treat the problem and then move on from there are really good options. Because again, if you stop with the medication, or example, you stop with Botox, then your symptoms will come back. We're not curing or reversing anything. Okay. Okay. Let's see. Okay, another great question. So there's another patient who has tried several different medications and is greatly improved, but is still disappointed that they have to wear pads. So there may be some room for improvement. And again, some of these third line options may get you 100% dry, but we really judge by 50% improvement. So if you see 50% improvement, then in the clinical trials and in the data, that is success. So we may not be able to get you 100% dry, but if we can greatly improve your quality of life, we call that a success. And then you and I again can discuss in person kind of what your goals of care are and what is a realistic goal. Okay, I think that is all of the questions, unless anyone saw any more. Okay, great. Well, again, it was my pleasure to discuss this with you all tonight. I hope that I provided some clarification and that you got some of your questions answered. Again, feel free to reach out. I'm happy to speak with any of you about this in more detail. And we have excellent, Medtronic does a great job with patient education. So we have excellent videos, which you can also find online. I have videos in my office and plenty of things to show you to really help things sink in and address any of your concerns. I hope I will be meeting some of you shortly, and have a great evening.